Welcome to Self Delivery Network. This is Dr. Mike and you. We are still continuing on the topic of preparing for self delivery part 2. And our topic today, we are taking it identifying high risk and low risk patients. Now, in the antenatal clinic, everything that we want to do on earth that we need success at the end of the day must be prepared for. Nobody appears at the Olympic meet without any preparation if the person hopes to win a medal. Delivery is the same. During pregnancy, women and their mentors and their spouses and husbands must prepare. Even the death attendants, those who are attending to these women in hospital, must prepare for safe delivery if the safe delivery shall be the outcome of pregnancy. So one of the best ways to prepare is to have an objectively time-honored antenatal care. Antenatal care that is proactive, antenatal care that preempts challenges that may cause misery during pregnancy and delivery. And for an antenatal care to provide that kind of safe delivery, you must be able to identify who are high-risk patients and who are low-risk patients. There is no risk-free pregnancy. Every pregnancy is risky, but some are high risk and some are low risk. If everybody knows that every pregnancy is risky, that means everybody should assess professionals who take care of pregnancy so as to be safe, because it's not written on the face of anybody who will have challenges, who will have problems, who will have bleeding, who will have obstructed labor, who may have infection, who may have eclampsia, who may have obstructed labor. There is nobody, it's not written on anybody's face, but through a thoroughly supervised antenatal care, one can know women that may be high risk or low risk. And those who are high risk patients, special attention will be paid to them. They may be given more frequent appointments, and things will be done for them to ensure that at the end of the day, they still come out alive and well with their babies. Who are the women that may have obstructed labor? Who are these women that may have obstructed labor? Obstructed labor is one of the major reasons for maternal mortality, maternal newborn mortality, and morbidity. Obstructed labor has been a reason for rupture uterus for those who are vulnerable. Rupture uterus have been known to cause massive intraperitoneal bleeding, massive bleeding into the peritoneal cavity or abdominal cavity, and death of baby, death of women if nothing is done quickly. Obstructed labor has been the reason for vesical vaginal fistula. For women that did not have uterine rupture, they may end up with vesical vaginal fistula, whereby the bladder, part of the bladder is destroyed by pressure of the fetal presenting part, the head of the baby, on the bony pelvis of the woman, causing sloughing off of the bladder and the wall of the vagina, so that urine now dribbles out of the woman uncontrollably. Obstructed labor causes nerve pulses, what we call obstetric nerve pulses. For women, the baby's head has been pressing on the lumbosacral trunk of the nervous system, and at the end of the day, some of them, the perineal nerves, the common perineal nerves are affected. They may be unable to walk well. Some of them may not even get out of bed. Some may have challenges on the bony pelvis, even necrosis, death of part of the bone of the pelvis. They are not able to walk well after delivery. Some will take long time of recovery before they can come out of bed. And so there is need to know which woman will obstruct, will have obstructed labor. Some of them may have severe anemia at the end of the day. They lost a lot of blood, and the blood was not replaced properly, and so they have the debility of anemia. Their blood level is low. They are unable to attend to their domestic chores, unable to take care of their babies, and may even die from anemic heart failure. So women that have obstructed labor may end up delivering a dead baby, and after the baby has died, the head collapsed, they deliver a dead baby. They may now have secondary infertility. They are not able to conceive again because infections set in, block their tubes. So then had Asherman syndrome, the uterine wall went into fibrosis because of infection of the endometrial cavity, the cavity of the uterus, and so they are unable to menstruate, or they menstruate scantily. Then some of them even have ovarian failure because the ovaries were also infected during the course of the prolonged labor or prolonged delivery that took place. So obstructed labor is a menace, is a problem. So how do we know the women that may obstruct? One of the ways to know is the history of delivery. The woman comes in, you find out what happened in her last delivery. It tells you that she has a prolonged labor, baby died shortly after delivery, or baby died in the course of delivery, or baby had caput succedaneum, that is, there was swelling on the scalp of the baby, or baby had molding, the head was molded, the hair was out of shape at delivery, or the woman will tell you, I labored for 3 days or 2 days before finally I delivered, or I labored for long. At the end of the day, I had a cesarean section, an emergency cesarean section. And then you're looking at the wound of the scar on the abdomen. The scar shows that the wound was poorly healed. That's a signal that the labor did not go well. That means something may have obstructed the labor. So such women must be subjected to further investigations, must check, do a pelvic assessment and know whether their pelvic is adequate or not. And sometimes you discover that you can easily reach the sacral promontory, or the cavity, or the concavity of the bone, the sacrum, is not deep enough, it's shallow. Then the outlet is narrow, the intertuberous diameter is narrow. So these are women that will benefit from an elective cesarean section. We have the bony pelvis here. This is what is called the sacral promontory. This is the pubic symphysis. So some of those women, the interval between this bone and this pubic symphysis, this is a biscuit bone in the front of every woman, in front of every man. This biscuit bone is called pubic symphysis. Now, the interval between this and this is usually like 12 centimeters or above. But in women that had obstructed labor due to pelvic contraction, this dimension is less than 10 centimeters. So the baby was not able to pass. Some of them, there's a bone here called the ischial spines. They are prominent. They are prominent. And if they are prominent, they narrow the interval between the ischial spines in the mid cavity. This is the sacrum. The curvature of the sacrum is concave. And in these women, you discover that the sacrum is not well curved. And so now this is called the ischial tuberosity. This ischial tuberosity, you discover that in some of those women, your hand cannot pass between the bones here, the ischial tuberosity. That means the interval from here to here is less than 8 centimeters. When it is like that, that woman will likely have obstructed labor in her next delivery. So such women can be offered an elective cesarean section to save the day and prevent them from having another obstructed labor. So from the history, that is from the story the woman told about her previous delivery, we can know. And again, from the scar on her tummy to show that she had an emergency cesarean section in her last delivery, you can know that this particular this particular pregnancy is high risk. High risk in the sense that it can lead to complications of certain level, and that complications can lead to unsavory events, either miseries or death. Like I mentioned, some of the miseries that could happen due to this of certain level. So the other thing is that you can also check the height of the patient. Most times, these women that have narrow pelvis or contracted pelvis are also short. So, but there's no hard and fast rule about it. You always put factors together to know which one. But one of the factors is the height. That's why we check the height of the woman to know whether she's short, even though height has something to do with ethnicity, where she's coming from. But even though there are some tall people that still have challenging pelvis, but all the same, there are so many factors we put together. Then, of course, these kind of people should be cancelled. They are not the type of people who should leave for unskilled birth attendant maternities or childbirth attendants who are not skilled, because, and of course, this kind of person should never receive oxytocin drip or oxytocin injection or cytotec or anything that will stimulate the uterus to promote labor, because she may actually rupture her uterus if this is done. So this is one of the things that we can say is high risk to those that may obstruct, those whose labors may obstruct, those that have tendency to obstruct a labor, people with pelvic, small pelvic dimension. Then the other group of people whose labors may obstruct are women with fibroids, especially if the fibroids are in the lower segment of the uterus. The uterus has an upper segment, or what they call the fundus, or the body of the uterus, and then you have a lower side of the uterus. Now this uterus, you can see the upper side, you can see the lower side. Now women who have fibroids located in the lower side, the fibroids may obstruct the baby, not allow the baby to pass. Or women who have placenta previa, the placenta is located at the lower aspect of the womb. These women may also have obstructed labor. We have noticed that a new trend in obstructed labor is the presence of the placenta in the lower segment. Most times the baby is trying to pass and get blocked, cannot pass, and so labor obstructs. So an ultrasound scan can help us in diagnosis, or a pre-conceptional diagnosis of fibroids, especially low-lying fibroid, can give it away that this woman is a high-risk patient. She may actually have obstructed labor. So obstructed labor can also be caused by accident. Somebody who had a roomy pelvis in the first pregnancy, but before this current pregnancy, she had an accident where she had fracture of the pelvic bone. And when the fracture healed, it can heal with callus formation. That is, the bone density increases, especially in these parts. The parts of this is the sacral promontory. This is sacrum. This is the ilium. There is a pubic bone. So any of these bones, if it has fracture and there's callus formation, healing by increased bone density, it can narrow the interval between the bones and lead to obstructed labor in the neck. So a history of fractured pelvis, fake bone, and even looking at the X-ray reports can give it away that this woman is a high-risk patient. She may actually have obstructed labor. Then you have women too that have subluxation. Now this is the sacral promontory. The lumbar vertebra is here. The fifth lumbar vertebra is the one that aborts this first sacral bone. Sometimes this bone can shift forward in what is called spondylolisthesis. spondylolisthesis, this bone, the bone on top of this one, shifts forward and narrows the interval between the sacropromontory, between this bone and the pubic symphysis. So a history of this shifting of bone at the back, a history of slip disc or shifting of bone at the back can give it away. That so some women, even if they have had 1 or 2 babies, it can still be good to do a clinical pelvimetry, that is, check the bones to know whether this woman can actually deliver without issues or have an obstructed labor. So the high risk pregnancy we are considering today is women that may have obstructed labor, women that have fibroids located in the lower segment, women that have placenta previa. The placenta previa is not producing bleeding, but it's obstructing the baby from passing. Women that had accidents, women that have subluxation of the lumbar vertebra, causing what we call spondylolisthesis, which reduce the space available to the baby to pass. Women with fetal macrosomia, their babies are big. So women delivered uneventfully 2.5 kg babies, 3.5 kg babies, but in the current pregnancy, the baby is more than 4 kg, 4.5 kg, 5 kg. That is a high-risk patient because that baby, the labor may obstruct. So in the antenatal clinic, it's our responsibility as the obstetricians and midwives to discover these women that may have obstructed labor. And by discovering them, we can offer them an elective cesarean section to save the day, or allow them go into labor, but intervene quickly before obstruction sets in to save lives. So thank you for listening to us on this channel, Safe Delivery Network, Dr. Mike and you. Please subscribe to our YouTube channel and also click on the notification bell. Like and follow us on Facebook, Instagram, Twitter at Safe Delivery Network. See you next Saturday. God bless.